Hello, everyone. Welcome to EPOMEC 2025 podcast. It's a pleasure to have a well-known international speaker with us today, Dr. Cathleen McCabe. Welcome to Dubai. I know this is your first time in here in EPOMEC.
Yes, it is. It's been a wonderful experience so far.
It's a pleasure to have Dr. McCabe with us. She's an expert in cataract, refractive surgery, coming all the way from Florida. Dr. McCabe, welcome. And how is your experience so far?
It's wonderful. The energy here is really fantastic. So many people that are sharing ideas and collaborating. It's been a pleasure to present some of our data and our thoughts on biometry so far, and I look forward to some of the videos that I can share later in the program.
Perfect. Since you talked about the scientific part, I have to ask you about the scientific since I'm looking at the scientific part of EPOMEC. So tell us, what are you presenting to the audience today in summary? I know that everyone is excited for your talks, but let's hear what is going to be new and innovative for us.
Yeah, so today we talked about what's new in biometry, what you shouldn't miss in 2025. And today that focused on modern formulas, making sure we're using the best methods that we have for determining what the implant power needs to be for our patients, optimizing the ocular surface, getting good data, and then using digital planning platforms to synthesize that data and then personalize it for the biometry and for the geometry of a patient.
That's great. I'm sure a lot of young ophthalmologists will be interested in those parts. We used to learn the biometry the old way, the simple way. And what is your advice for the young cataract surgeons in attending EPOMEC?
Yeah, so I mean, I think in a lot of ways they have it easier than we had it when we only had very simple formulas that were not good for every eye and really were not as accurate as what we would want. So we know that those traditional formulas, about 70%, 75% at the best, were within a half diopter of the target. Today, with modern formulas, we can get about 81% or so. But if we combine that with digital planning software, we can be in the 90s, mid 90s and above, actually. So I think what's exciting is they know that they can target better. And the methods that they have for analyzing their outcomes and improving are so much easier and so much better today.
That's great. What about the latest IOLs in the market? I know that nowadays the choices are wide and there's a variety of IOLs. There is the multifocal, of course, the monofocal and the toric, multifocals, EDOF. And I know that you are presenting how to personalize the choice for your patients. Any advice you want to give us for the audience?
Yeah, I mean, today we're again so fortunate that we have so many good technologies that really minimize the side effects and the compromises that we need to offer patients, meaning dysphotopsias and maybe decreasing quality of vision that we had before. Today, our trifocals and our full range of vision lenses really give excellent quality of distance vision, which we now know is so important. Nobody wants to sacrifice that, and really minimize those dysphotopsias that patients wouldn't want to experience when they're trying to achieve that full range of vision. So, it's almost hard to go wrong in a lot of ways. So today, it's more incumbent on what are the needs of the patient. So really listening to the patient, and then have we look sufficiently at the health of the eye? Do we look carefully for early signs of progressive disease so that 10 years from now, we've still made the right choice for the patient? So I think in the past, we really were focused on one-day postoperative results. And today, I'm really thinking about the lifetime of the patient and what's best to meet that patient's needs over their lifetime because we have such good options. I think another thing that we're really better at is both diagnosing, measuring, and understanding astigmatism, and then targeting that very, very specifically. We actually have lenses that target that with even closer steps, going lower and higher than we ever had before in astigmatic correction. And that importance of really nailing astigmatism correction has become more and more evident with the more advanced technologies that we have.
That's beautiful. This is actually what I believe in. We shouldn't try to fix presbyopia before fixing the astigmatism.
It's foundational.
And it's foundational. And
Yeah.
I see some of unhappy patients who are not happy with the multifocal because their astigmatism was not addressed, or let me rephrase it, it was addressed with arcuate incision or inaccurate or like less accurate method, while we have the toric IOLs, which is beautiful and targeting the astigmatism in a very nice way.
Completely agree with you. Yeah, it's
Yeah.
always better to go with a low power toric, which we now have good options there, than an arcuate incision that may worsen their ocular surface quality as well as being less accurate.
Let me challenge you with a question, because we started to face these questions nowadays. Those post LASIK patients who are now developing cataract, we start seeing them a lot in our clinic.
Yes.
And I'm sure in the next few years and couple of like decades, there will be more and more. So do we have anything solid right now? Do we still pick and choose which one will be benefiting from the multifocals and presbyopia correcting lenses? Or do you have anything new you want to advise us about?
Such a great question, because those are some of our more challenging patients, right? We're not as good at targeting those patients, number one. We know how important it is to actually understand posterior corneal curvature in those patients. So more advanced formulas like the Barrett Universal True KTK is much better at targeting properly for those. We understand now how higher order aberrations and advanced optics may interact with complex corneas in a less favorable way for quality of vision. So, thankfully we have things like monofocal plus lenses like Aspire and Eyehance and others like that are helpful for those patients. Many times those patients have had monovision, where we can replicate monovision. In the US, we have the light adjustable lens, which has been a powerful tool. And something new that we're doing in our practice is actually taking those patients that are harder to target and in their non-dominant eye, using a small aperture lens, because that can give them some range of vision and refractive forgiveness, which often is what we really are challenged by in those patients. And then targeting in their other eye, maybe a neutral asphericity lens that also will work well with whatever changes they've had in their spherical aberration. So we think in a little more sophisticated way now about those more complex patients in order to set expectations reasonably, but also deliver the highest quality outcomes.
I agree. I still do the same, but it's always, we don't have the full picture. And yeah, sometimes you need to lower the expectation, as you say, and choose the best candidate for it.
I agree.
Thanks a lot. It was really nice talking to you, and thanks a lot for joining us at the EPOMEC 2025. And hopefully we'll see you in the future as well.
Thank you so much for the invitation here. I'm so excited to be here as well.
Thank you. Have a good day.